is a national webinar. I'm going to say good morning and good afternoon. So welcome to our webinar today, Paying for HIV Prevention, Reimbursement, and Sustainable Payer Sources. This webinar is a collaborative effort between Primary Care Development Corporation, PCDC, and the National Alliance of State and Territorial AIDS Directors, NASDAD. My name is Sara Smith, and I'm the Program Director for PCDC's CDC-funded Capacity Building Assistance Program, HIP in Healthcare. More on that in a moment. And we're just very pleased that you've joined us today, and we hope that you'll be able to use the information in this presentation to support and sustain the crucial HIV prevention services that you provide to your patients. So a little bit about PCDC, and we'll hear from NASDAD in just a moment as well. So PCDC has worked since 1993 to catalyze excellence in primary care through strategic community investment, capacity building, and policy initiatives to achieve health equity. While we're based in New York City, we also have an office in Los Angeles, and we work across the country to support the infrastructure and delivery of high-quality primary care. We have three main programs: capital investment, performance improvement, and policy advocacy, which work together to support our mission. PCDC's HIP and Healthcare program is funded by the Centers for Disease Control and Prevention to build the capacity of healthcare organizations to respond to the new HIV prevention landscape and integrate high-impact prevention strategies. Through this funding, we are able to provide free training and technical assistance. I'll say that one more time: free training and technical assistance to healthcare organizations across the country. So what is HIP? HIP stands for High Impact HIV Prevention, which is CDC's approach to reducing HIV infection in the United States. High Impact HIV Prevention works to advance the National HIV/AIDS Strategy and aims to maximize the effectiveness of current HIV prevention methods through combinations of scientifically proven, cost-effective, and scalable interventions targeted to the right populations in the right geographic areas. So I will now turn it over to my colleague, Amy Killey from NASDAD, to just explain a little bit about who NASDAD is. Amy?
Thanks, Sarah. Hi, everyone. This is Amy from NASDAD. And just very briefly, NASDAD, we are an association. We represent the individuals at the state health departments who oversee HIV and hepatitis programs. You've got a little bit more on your slide there about NASDAD's mission and our vision. As Sarah said, we are also a CDC capacity building assistance provider focused on capacity building assistance for health departments. And one of the areas that we're going to talk about today that NASDAD supports is policy support and capacity building for health departments, partnerships with health systems and payers.
Thanks, Amy. So we are part of a network. PCDC and NASDAD are part of the National Capacity Building Provider Network, as we've noted. We're a network of 21 organizations focused on building the capacity of the nation's HIV prevention workforce in three settings. NASDAD is funded to work with health departments, and PCDC is funded to work with healthcare organizations. But again, we have a network of organizations across the country that are funded to work in all three settings that you see on this slide. And we do provide free training in TA in the following areas: HIV testing, prevention with HIV positive persons, prevention with HIV negative persons, condom distribution, organizational development and management, and policy. So our learning objectives for today's presentation. By the end of this webinar, we hope that you will have an increased understanding of today's healthcare landscape and how this impacts reimbursement for HIV prevention services, increased understanding of NASDAD's billing coding guide for HIV prevention and how to utilize this resource to support reimbursement for HIV prevention services, increased awareness of state-level strategies to assess HIV prevention reimbursement opportunities, and increased awareness of strategies that other healthcare organizations have used to improve reimbursement for HIV prevention services. And how we're going to work our presentation today is that we're going to have two main presentations. One will be from Amy from NASDAD, and she will really set the stage and speak about the Affordable Care Act and health system transformation She'll also speak about the specifics of NASAD's billing coding guide and how to use it. Amy will also outline some ways to look at your state and how to understand what specifically is going on in your state and how you can use different kinds of initiatives to support reimbursement for HIV prevention. And then we're going to hear from Harlem United, and we're going to hear about how Harlem United really has proactively built a very comprehensive billing infrastructure to really support their HIV prevention services. And then we hope to have a pretty robust Q&A. We're really trying to save the last 30 minutes of this hour and a half for a moment where we can really hear from you about specific questions you might have. And so what we're going to ask you to do is that as the presentation continues today, please type your questions into the question box. And we will not answer them as we go, but we will hold them till the end, and we'll review the questions and then give them to Amy and Tanisha McPherson from Harlem United to really address those questions. And so before I turn it over to Amy, I just wanted to provide a little bit of context for today's presentation. So PCDC has now been working for 3 years as a capacity building assistance provider for healthcare organizations. We have really done a lot of work around supporting best practices for prevention, such as HIV testing, linkage to care, and PrEP. And what we have seen is that there's a real need to understand how to bill for these services and how to get reimbursed for these services. So we were really thrilled when we saw that NASDAD had worked to put together a very comprehensive and very concrete guide, the Billing and Coding Guide for HIV Prevention. And so we really wanted to step up and try and disseminate this really valuable resource to healthcare organizations across the country, as this is a really great way to really try and think about strategies to support reimbursement. So with that, let me introduce Amy Killalay. So Amy Killalay is the Director of Health Systems Integration. She has, excuse me, thank you. She leads NASDAD's health reform, public and private insurance, and healthcare financing efforts, including providing resources and technical assistance for state HIV programs and developing recommendations to inform state and federal policy. Prior to joining NASDAD, Amy worked as a senior fellow in Harvard's Law School Center for Health Law and Policy Innovation, conducting legal and regulatory analysis of federal healthcare reform, Medicaid, and private insurance. So, without further ado, Amy Killalay.
Great, thank you, and hi everyone. So what I'm going to do, I'm going to talk about NASDAD's billing and coding guide, but I want to give some context before we get into the specifics of billing and reimbursement opportunities and some emerging coverage opportunities going on out there in your jurisdictions. And the context I want to provide is really for the why of the accelerated focus on billing and reimbursement opportunities for HIV prevention. I think it's very much in response to a number of factors, both within the HIV prevention field itself, and then within the broader healthcare landscape. And so there's a lot going on, but I just want to talk about 3 in particular. And the first is really sort of an inward focus. Our HIV prevention paradigm has and is continuing to change. With the relatively recent advent of things like pre-exposure prophylaxis, coupled with a focus on treatment as prevention, we've really seen the necessity for these new partnerships, new and strong partnerships with both health systems and clinical systems in particular, and payers. And I think the reason being is that we're talking about biomedical interventions, and because particularly of the medication component, and we're going to talk a lot about PrEP as we go. The clinical system has become a necessary partner, and particularly again for PrEP, the public and private insurance world has been necessary as a partnership to really provide that payer source for critical services. So on the same vein, just as our HIV prevention and public health world is changing, so is the way that insurance and particularly Medicaid. We're going to focus a lot on what Medicaid's doing, what it could do. But that world is changing the way that it thinks about public health, and that it pays for public health and prevention services. So just in the past, I would say like 5 years, that there's been a real sea shift in how Medicaid pays for and delivers services. And we're going to talk about, the specifics of where opportunities for HIV prevention have opened up a little bit later on. But, the real takeaway here is that because Medicaid is paying attention to population health and really looking at sort of the better ways to address the upstream factors and social determinants of health that we know impact, for Medicaid beneficiary health, there's new opportunities for HIV prevention programs and providers in the Medicaid space that really didn't exist before. And then finally, and I think this is sort of a familiar slide and talking point for folks, but I think the importance, deserves to be underscored. We're in the midst of a massive insurance shift as a result primarily of the Affordable Care Act. Since the expansion of Medicaid and access to private insurance through qualified health plans has gone into effect, millions of Americans have gotten coverage, including many, many people both living with HIV and at risk for HIV. So, this slide and this graph just shows you that the impact has been an unprecedented reduction in the uninsured rate in this country. So this obviously impacts the ability of HIV prevention providers to actually bill for services, because you're seeing people walk through your doors with an insurance card in hand, where prior to the ACA, you just didn't see that too often. And, I should say, and I think it's important, and I'll try to do this throughout, a sort of a word about our new environment. We are obviously expecting some changes to the Affordable Care Act and our sort of health coverage landscape in the coming months and years with the new administration and Congress. There's just going to be a lot to be determined in the coming months about what those changes are going to look like. But I also say, there's also a lot of momentum behind holding on to these incredible gains to reduce the national uninsured rate. So it's something to monitor. It's a bit of a moving target, and also underscore the places to keep a lookout as we go. And I think just the takeaway here is that through all of these changes and sort of new partnership opportunities, we're seeing new opportunities for HIV programs and providers to demonstrate that what they do, particularly along the care continuum and using that framework for what it is that we in HIV prevention and care do, to really sort of articulate the value of that to payers and systems in a way that resonates within payers and systems in terms of what they care about and what they do. And what they care about is really this triple aim, this trifecta of goals for the healthcare systems and payers of, better healthcare for individuals, better healthcare for populations, and overall reduced costs. And so, we as public health, by nature of what we do and how we do it, by nature of the amazing work going out there by all of you, have an important voice in that broader health system conversation. And we'll talk about sort of how that translates to particular, coverage opportunities. So, in addition, we talked about sort of the trifecta of changes I spoke about with the Affordable Care Act and expanded access to insurance coverage coupled with the health system transformation that's happening in Medicaid. I would also just note that, and this is likely obvious to many of you out there, but constrained state and federal funding for HIV prevention and for public health has added another impetus for leveraging reimbursement for services. And I think, in terms of the benefits of billing commercial and public insurance for services, there are a lot. We talked about sort of closing budget gaps and addressing constrained grant funding, and sort of as one tool and one step to achieve overall sort of fiscal sustainability. And I do want to note too, there is a way in which this conversation has to be sort of state and jurisdiction specific. And one of the reasons is that we know the health insurance landscape looks different depending on what state you're in, particularly if you are in one of the 19 states that has not yet expanded Medicaid. So the opportunities are going to be different. And I would say, I would soften this a little bit to say that folks out there in the non-Medicaid expansion states may have somewhat fewer and different opportunities, but we're going to talk about sort of what those non-Medicaid expansion opportunities actually look like a little bit later, because they do look like something. There are opportunities and there are things happening there for HIV prevention. And I think our other speaker is going to talk about sort of the specifics of implementation and addressing challenges when it comes to billing and reimbursement. And there are many, and I'll sort of read through these and note we're not going to address all of these today. It's not possible to do that in one presentation, but it's complex, and I want to note that there are many moving pieces of complexity. The culture shift, changing from what has traditionally been sort of free public health services offered on an anonymous basis. You're changing that to something that's different, that somebody presents their insurance card. Working with private insurers who speak a different language is challenging in and of itself. Billing infrastructure is resource heavy and challenged. The need for electronic health records is something that's difficult, particularly for smaller providers. The client confidentiality piece, sort of everything that goes with really the math of it all. And I think that's what most of this this slide sort of articulates, that getting a good unit cost analysis for what you're providing now and translating that into sort of a contract and reimbursable services that a payer understands, that's hard. So all of this stuff that is sort of the complex pieces of ramping up billing and reimbursement, and we will not be talking about all of this, but know that it's on our radar, and something that is just part and parcel of moving in the direction of billing and reimbursement. What we are going to talk about today in greater detail is the bullet point in red under there of really understanding the billing and coding opportunities for HIV prevention services. So with that kind of context and overview, I want to move into a discussion of NASDAD's billing and coding guide. And I'm going to talk a little bit about sort of how it came about, what areas we really wanted to identify and cover, and briefly sort of how to use it. So, at the outset, so NASDAD, through our capacity building assistance work through CDC, we sort of identified this challenge that we were hearing from health departments and their contracted providers on, this translation piece of how do you translate, public health, HIV prevention services into a language and sort of a CPT code, nomenclature that will resonate and will get paid for by third-party payers. And so what we did at the outset was to convene an advisory group that was made up of a coding expert, a certified coder who could help us with that part, the HIV Medicine Association, health department staff, and then individual clinical providers to really inform, what should we include in this billing and coding guide, and sort of how do we do that in a way that's going to be useful for folks. And so through that advisory group process, and just through conversations with health departments and their contracted providers, we identified, several areas that were sort of sticking points for the billing and coding world. And so, at first was around PrEP. That because PrEP was a relatively new intervention, it was difficult to bill for because not all providers were using, the same diagnosis codes in particular, or the same sort of protocol for which codes to bill for when it came to the full gamut of PrEP. So that was one area. HIV linkage and care coordination services, we heard again and again that was a difficult area to really get an accurate sort of translation into billable services and units. And then we heard, that payer restrictions on provider credentialing, what types of providers and what places of services are going to be eligible for reimbursement were a significant barrier. And this is, particularly true for community-based providers and settings. So those were sort of the broad parameters that we wanted to address with this particular guide. And that translated into 3 areas of focus. And I'll go through kind of a brief description of each of these areas. PrEP, initiation and follow-up, adherence, linkage and counseling services, and then lab tests for HIV and STI. So, in terms of how to use the guide and what you'll find in there, you'll find sort of divided by those 3 buckets of service categories, a translation identifying the appropriate CPT code or codes that go with the different services for each category, the provider requirements and credentialing and licensure requirements to be on the lookout. Those will vary by payer, but sort of underscoring where there is variability in terms of that credentialing and other requirements for provider, and then the allowable ICD-10 diagnosis codes. And included in there that you'll find are sort of little like case studies walking through how different scenarios would play out and sort of what codes and you would use. So, for each of these 3 buckets, what I'm going to do is just give a quick example of what you can find in the guide. And what I'm not going to do is sort of a dramatic reading of the entire guide, which is lengthy and covers a lot of ground, and it's got a lot of CPT codes and different service scenarios in there. So I'm not going to do that, but I just want to give you an idea of what's in there. And so to start on our sort of first bucket of services, and that's PrEP. So, for what we did for PrEP, and again, sort of in response to what we heard from our advisory group, and particularly, the clinical providers on this advisory group really talking through the challenges they were having in figuring out sort of the magic combination of CPT and diagnosis codes to use to get paid for, the ancillary services that accompanied a sort of PrEP medication. So we looked at, the codes for initiating PrEP, including counseling patients and the testing for HIV and STDs. And then, hearing the inconsistency in terms of what diagnosis codes you use for PrEP. It's that you can read all of the ICD-10 codes, and you will not see a code that is specifically right for a PrEP prescription, because that doesn't exist. Your PrEP is not a diagnosis code, or eligible for PrEP is not a diagnosis code. So then figuring out, all right, of the existing diagnosis codes, which one makes most sense and which ones have the most success in practice of getting paid. And so you'll see in the guide sort of walking through some of those best practices that we identified from those conversations with clinical providers who are doing this. On adherence, linkage, and counseling services, and we'll talk a little bit more when we get into the sort of state coverage landscape and coverage opportunities, but this was a tricky one. If we look on the left there for our prevention world, our nomenclature for these types of services, HIV adherence, HIV linkage, counseling services, you can look in your CPT code book, you can read the whole thing, and linkage really isn't in there. And so that there was just a sort of at the outset a translation challenge to overcome of, okay, when we say, HIV adherence, linkage, and counseling, what component parts can we divide that into that does resonate and that does have a CPT code and sort of service coverage category for a payer? And I think you could do this with any number of HIV prevention and public health services. It was just particularly relevant for this sort of suite of services. And so when we did do that translation, we do see that some categories are good fits. Particularly in the Medicaid space, where I think there's more attention to some of this care management and case management, risk counseling. So you've got some of those translated benefits categories and coverage categories. I think the other piece that I sort of forecasted at the outset of a real challenge was that depending on the payer, those credentialing requirements really can and do foreclose billing for a lot of HIV prevention providers. So even if you translate your services accurately and appropriately, and you find your CPT codes, the problem is that a lot of the payers have credentialing requirements that really limit, particularly for community health workers or other community-based providers that maybe don't have the licensure that many payers require. So it's really foreclosing billing and reimbursement for those providers, even though you're providing covered services. You just don't have the appropriate credentialing requirements that the payer looks for. So I want to note that just is a challenge out there, and I think we've seen in the policy world some movement, particularly recently, to sort of widen that realm of providers who can bill for services. Particularly, again, Medicaid, I think, is leading the charge here, and we'll talk about what some of that looks like out there in the states. But it continues to be a real challenge and a lot of variation, between payers and between state Medicaid programs. So for this third category of services, lab services, and this one I think is probably the most straightforward, frankly, and the most work had been done, by others prior to NASDAD's coding guide tackling these services in particular. So I think many of you out there on the webinar today are probably familiar with some of those HIV testing and coding guides that are in existence and that are great. So, what we paid special attention to in the guide and sort of what we heard was a remaining kind of problem. We paid special attention to the Affordable Care Act related requirements around provision of U.S. Preventative Services Task Force recommended services that have to be provided without cost sharing in private insurance and Medicaid expansion, and looking at, when those services get billed as the ACA preventative services versus when and how they get billed as diagnostic. And this came up particularly, we were talking about PrEP in those ancillary services that go along with PrEP coverage when you've got folks who are getting tested multiple times a year. So, it's covered, but the coding piece is that it's covered as a diagnostic test and not, as routine screening when it's the multiple times a year for PrEP. So that was just the sort of the scenario that we tried to address in that lab services component. So that kind of gives you a sort of brief glimpse into some of the tricky situations that we covered in the coding guide. And I want to underscore that, the coding guide did not solve all of our problems in terms of billing and reimbursement. And so, there are still limitations and challenges to really maximizing to the hilt, that new coverage opportunities and reimbursement through third-party payers for HIV prevention services. And I include some of those, and I mentioned some of these as we go. Many HIV prevention services, despite our best and creative efforts, simply don't translate well into the language of payers. You just simply will not find service coverage category for everything that public health does, and nor should you. I think there are some things that public health does well and will hold on to. So that was a challenge. We talked about credentialing. Even though we're going to talk about some of these emerging opportunities, it's far from universal right now, and some of the credentialing requirements really do get in the way of maximizing these opportunities for HIV prevention. Reimbursement rates, and these are sort of the last two bullets, which we will not be talking about really in any detail today, but I just want to sort of note that it's a problem. Reimbursement rates, particularly for Medicaid, are often lower than both the grant funding that providers are getting for these services and, in some cases, the actual cost of providing the services. That's a challenge. And then, finally, the global rates that are often applied to sort of packages and encounters instead of, a fee-for-service fee for each service. That's difficult. That makes it hard, particularly for some healthcare organizations, to really maximize some of the HIV prevention reimbursement opportunities. This is particularly tough for FQHCs and emergency departments who do not operate in the sort of fee-for-service world, who do much more operate in this global payment for an encounter or patient. And if that global payment rate doesn't take into account all the services that healthcare organizations and providers are providing, then that's a disincentive to add anything new like HIV testing. So those rates, changing those rates to encompass all the services that folks really need to provide takes time, and that's often a larger institutional conversation and commitment. So we're not going to get into the intricacies of that, but I want to note that that's another sort of challenge going forward. So that gives you kind of the rapid fire walkthrough of our coding guide. And happy to answer questions about that when we get to Q&A, but I want to shift our attention a little bit, because I think one of the things that we found in the coding guide for some of these services is that we could identify in the coding guide the opportunities, but really there's still a lot of state variation and plan and payer variation in terms of whether and how they cover those services. And so I want to walk through some considerations for your state's coverage landscape, areas that I think are sort of shifting and moving, and sort of opportunities that have opened up, particularly again like in the past 5 years. And I want to focus on Medicaid in particular, and because I think again in terms of where our populations are, Medicaid is the low income program for healthcare coverage. So this is going to be sort of our focus area, our friendliest partner in terms of HIV prevention and public health. That's not to say there are no opportunities in the commercial insurance space, but I think there are a little bit more in Medicaid and more of a moving target in terms of innovative things that state Medicaid programs are doing. So, as I mentioned at the outset, Medicaid is changing in terms of the opportunities that are opening up pretty much in every state right now. There's been an incredible investment at the federal level to really changing and supporting at the state level, because as we know, Medicaid is a state and federal partnership, changing how Medicaid does business, and really allowing more flexibility to pay for and deliver services in new ways that I think really put a thumb on the scale of, as I said before, those upstream drivers of health and social determinants of health. And that opens up space for HIV prevention and for public health providers. And you've got like a whole sort of alphabet soup list of different ways that Medicaid programs are sort of availing themselves of these new initiatives and federal funding and federal programs. I'm going to go through sort of examples of these as we go. I'm not going to sort of read them all out to you right now, but I will say, like, I think there are 3 takeaways from this incredible movement in federal investment in Medicaid transformation. The first is that you'll see, and you are seeing, in your states, that as part of these payment and delivery reform models, community-based providers that are as we all well know, but Medicaid is starting to realize, are well poised to reach hard-to-reach populations that are at greater risk for HIV, populations living with HIV and other chronic conditions. Community-based providers are able to do that in a way that other providers are not, and so there are sort of spaces opening up to encompass services and provider types that were not part of the Medicaid system prior. In addition to sort of opening up spaces for providers, we've also seen opening up of the services that Medicaid will pay for and cover, including those services that link people to care and keep them adherent. Probably the words of the day for Medicaid in the past 5 years have been health homes and care coordination, and those have been incredibly important parts of some of the ways that state Medicaid programs have been transforming. And then finally, the third piece, the third takeaway that I think is kind of goes throughout all of these different initiatives is an emphasis on value. How do we design a healthcare system in a way that reduces hospitalizations, reduces emergency department visits? And I think that where space is opening up is that public health and HIV prevention providers and our sort of system of care has a lot to bring, has a lot of value to bring to that conversation in terms of averting new infections and keeping people virally suppressed so that their health does not decline. That there's a way that we can and should and are participating in these value conversations in new ways with health systems and payers. And what I want to emphasize, even in non-Medicaid expansion states, this is happening. So I'm sure some of you out there may be sitting in states thinking, well, gosh, my state did not expand Medicaid. This isn't happening here. This isn't relevant for me. This is happening everywhere. An intention to doing things differently in terms of how we structure Medicaid and how we pay for and deliver services in Medicaid. That's happening everywhere. And I also would say too, if you're also thinking like, gosh, Medicaid might be changing, and it might. I think this movement to value-based care, number one, like that has momentum behind it, and that's not just momentum coming from consumer advocates in public health. That there's a real interest on behalf of payers to move in a value-based care direction, and that's very much a bipartisan issue because it's got something for everybody. I think increased efficiency in the system works for payers and Medicaid programs. Paying for outcomes, focusing on overall better outcomes at the individual and population health level. Those are things that I think have a lot of momentum behind them. So I think even though we are going to be having a national conversation about Medicaid and what that looks like, I don't think we will lose all of this momentum toward value-based care in the Medicaid program. And for those of you who still don't believe me that you've got something going on in the payment delivery reform realm in your state, the Federal Centers for Medicare and Medicaid Services, the agency that oversees the Medicaid program, they actually have some great, easily usable sort of tools to look up exactly what your state is doing. So we're going to go through like what some of this looks like in states so you have a better sort of context. But you can look to see, did my state submit a state plan amendment or a waiver or other sort of demonstration project, and how might it impact public health? So those are just sort of easy links for you to look up by state, what exactly is going on there. So I'm going to end with just to give some real-life, real-world examples of how this is playing out and where the spaces are opening up for HIV prevention and what are sort of much broader, payment delivery reform and health system transformation efforts in Medicaid. And the examples I'm going to provide, I'm going to do like 3, and I'm going to move from sort of most expensive, complicated lift to sort of the low-hanging fruit of opportunity. And so the first example are through these Medicaid waivers. So some of you may be familiar with 1115 waivers, some of you may not. That's probably a presentation in and of itself, but the long and short of it is that it's essentially a demonstration project. It's a way for a state Medicaid program to say to the federal government, hey, I want to try something new and how I operate my Medicaid program. I want to do something differently with how I pay for and deliver services, but I need flexibility from federal rules to really do this. And so the federal government reviews and says, have at it, we think this is valuable. And so, these waivers are often massive. They take a long time to structure. There's a extensive application process that goes through the state and then is approved by the federal government. So they deal with a whole lot more than public health, but many of them are providing these openings for HIV prevention and public health in different ways. So you've got 3 examples here of different states, differently situated states that are pursuing 1115 waivers and that are opening up some spaces that have really impacted HIV. And so the first one is California is in the midst of an 1115 waiver proposal looking to incorporate community health workers into Medicaid. So to get a reimbursement mechanism for the services, some of which are prevention services that community health workers provide from Medicaid. So kind of taking care of that credentialing problem that we saw before. Other 1115 waivers like the one in Texas. So Texas is not a Medicaid expansion state. They pursued a fairly extensive 1115 waiver, and part of what they did is to offer a way to do different projects throughout the state, several of which encompass HIV linkage services. And then Mississippi, again, not a Medicaid expansion state, but using the waiver to provide family planning services for both women and men, and then within family planning services, providing HIV prevention services, including access to PrEP. So those are some examples of the big scope, 1115 waiver and what states are doing. The second tier, the next level, so this isn't quite as sort of onerous as going through an 1115 waiver proposal. States do state plan amendments to their Medicaid program pretty regularly. It's not as heavy a lift. And again, those state plan amendments are often extensive, but have opened up these spaces for HIV prevention. So Louisiana, again, they used, instead of a waiver, they did this a little bit easier route, used a state plan amendment to extend family planning services to men. You know, as you all know, the family planning services typically were only available for women, but more and more states have opened it up for men, and then you know, you can include HIV testing in there and other STD testing. Wisconsin, you know, used a state plan amendment to implement a health home program, providing these care coordination services, including, you know, linkage services for people living with HIV. And then, you know, DC working to assess, so I've not done this, but assessing opportunities to use the state plan amendment to increase use of community health workers. So just another mechanism to get community health workers and peers into the reimbursement mix. And then the last one that I want to talk about, and I think this is the lowest hanging fruit, because Medicaid managed care is in every single state. That's the way that states are moving and that most states structure their Medicaid programs. You all are probably familiar with the different Medicaid managed care plans that operate in your state. You may have relationships with some of these managed care plans. You know, they often have a little bit more flexibility to cover non-traditional services that ultimately, from, you know, a managed care plan perspective, are going to improve care for their beneficiaries. That is what they want to do. That is where sort of their and the public health HIV prevention goals align. So this is one, you know, NAFTA about a year ago released a series of case studies for Medicaid financing opportunities for HIV prevention, one of which highlighted Louisiana's model, where they worked with their Medicaid managed care plans to implement a pay-for-performance, so there was an extra incentive for plans to do this, quality measure for HIV viral suppression. So, you know, every plan is now measuring the percentage of their beneficiaries that reach HIV viral suppression. And they are assessed on it, and there's an incentive for them to do that. So that has a real positive impact on ensuring that Medicaid is a public health partner, you know, because there's an incentive attached to it. And it's really sort of formed relationships between public health programs and providers and Medicaid. So that you can do a lot of different things, not just, you know, a quality measure in Medicaid managed care plans, but, you know, there are also opportunities to cover, you know, different types of linkage and care coordination services. And we're seeing, you know, examples of provider relationships and contracting relationships with Medicaid managed care plans sort of pop up all over the country, sort of utilizing that extra flexibility that these managed care plans have. So that's, I think, something to really watch, and I think is an opportunity to look out for in every jurisdiction, because that's really a provider and plan relationship. So that was quick, and that kind of brings you through some concrete coverage examples. So now I'm going to turn it over to our next speaker to get into a little bit more detail on what this looks like from a provider perspective.
Thanks, Amy. Thank you so much for that presentation. And again, there will be an opportunity to ask Amy questions at the end. And we've just to address a couple of questions that have been coming through about slide dissemination. We definitely will be providing a copy of these slides to all folks who are on the webinar today, as well as a link to NASDAD's billing and coding guide. So all those things will be made available to you. So at this point, we're going to turn it over to Harlem United, which is a healthcare organization based in New York City. We are thrilled to have them on the phone today, because it is always great to actually hear from a healthcare organization that's really, you know, billing and coding and thinking about their infrastructure in real time. And so we're thrilled to have Tanisha McPherson presenting today. She is the Chief Program Officer at Harlem United. Tanisha came to Harlem United in 2010 as the Associate Vice President of Health Services and climbed the ranks to VP of Managed Care, Billing, and Credentialing, and again to her current position as Chief Program Officer. Tanisha's 20-plus year career in the healthcare industry speaks to her unique breadth of knowledge. She has expertise in leadership, practice administration, HIPAA, electronic health records, medical billing and compliance, medical coding, and revenue cycle management. Tanisha is a mentor and a coach, and in addition to training staff at Harlem United, she's an adjunct professor at many various colleges in New York City. So we're really thrilled to have Tanisha on the phone with us today, and I will turn it over to her to talk about Harlem United and how they have really built a very comprehensive billing infrastructure to really have a fiscal plan for HIV prevention services. Tanisha.
Thank you, Sarah. Good afternoon, everyone. And Sarah, you gave a great intro, and I want to jump right in to talk a little bit more about Harlem United. And over the years, Harlem United has grown from a HIV-only agency to now expanding to offering supportive housing, as well as we have a huge prevention program, as well as primary care, which covers primary care with our dentists, individual family counseling, HIV and STI testing, sexual health counseling, LGBTQ support groups, and care coordination. What really stands out for us as an agency, though, is that our prevention department does a lot of our preventive work, which helps really transition our clients into our clinics, but most of those programs are grant funded. Once the client actually touches our clinic, that's where the care coordination will now begin with our primary care providers, and depending on what the needs are of the client, assessing their needs and actually treating them, which will lead and can lead to a billable visit. And what I'm going to explain today is really the broader aspect of an agency that outsourced billing for years, and we used an outsourced billing company to really bill for all of our clinic services. And we brought billing in-house about 3 years ago. And what I'm going to share with everyone today is really, one, how do we maximize revenue and working with the insurance companies, and really talking a little bit about your contracts as well as our credentialing department. And if you can go to the next slide. A little bit about our mission. We provide 100% access to HIV and AIDS care for all of our clients. And I'm not going to read the full mission, but what I will share with you, over the years, the agency has really transformed into expanded services, and we're in the process of updating our mission statement and vision statement because our client body has changed over the years. So with that said, we are now seeing a lot more homeless clients. Our HIV clientele is still at a peak, but we are looking at, one, again, how do we meet clients where they are to continue offering the services that we've been offering for years, and making sure and ensure that we are getting paid for those services as well. You can move to the next slide. So with that said, what we had to do with bringing billing in-house, which I know a lot of agencies now across the country are moving into that third-party billing arena of now seeing that a lot of grants that they used to receive, those grants may be ending, or there has been a decrease in funding, and looking at other ways of how you can get paid for services. What we did as an agency, and because we had the prevention department and primary care, we decided to bring billing in-house and really looked at other agencies, not only in New York, but across the country. We visited other centers to see what they were doing before finalizing and actually transitioning billing in-house, of building the right team. So currently we have about 8 staff that fall in the billing department, and we bill for different types of services. So we have a health home department, we have adult day program, we have our federal qualified healthcare center, and then we have our Article 28, which we provide primary care, mental health, and dental, and then our Article 31. So it's a lot of different types of billing that we are actually working on, and there's a lot of details that comes with each of those programs that we have to look at and make sure we have the appropriate staff and credentialed staff to actually bill for those services. Next slide. So overall, the billing department submits claims on a daily basis to about 20 different insurance plans that the agency is currently credentialed with: Medicaid, Medicaid managed care plans. We have a host of HMOs, and special needs plans, and we actually participate with Medicare lines of business. But I do want to talk a little bit about those 20 insurances, because when we speak to other agencies, the first question that comes up, well, why are you participating with so many health insurances? And for us, because we're Article 28 and with the FQHC, we should not be turning away clients for the inability to pay. So in the state of New York, we do qualify for something called the wraparound services as a FQHC. So those clients that come in, and depending on the managed care plans that we actually contract with, they may pay us $30 to $40. We get an enhanced rate from the state, and that varies per agency, but it can range from anywhere to $100 to $190 to help make us whole. And that's individual agency, and that depends on how many clients you're seeing, and that's evaluated every year through your audit. But with that said, the 20 insurance plans, the one thing that we did when we brought billing in-house was to build strong relationships with those insurance companies, as well as hire our credentialing specialist who works with each insurance company individually and building a relationship with the credentialing department as well as our billing department. And my role about 2.5 years ago was the VP of Billing, where we met with our health insurance companies and representatives on a monthly basis to build those appropriate relationships, monitoring our denials at a peak, and I'll talk a little bit about that in the next slide. But I really want to stress the importance of the relationship building, because it's important to see clients, and definitely we all treat our clients and we want to get paid for those services. But if you don't have the updated contracts, no one is reviewing the contracts, no one is reviewing your denials to see what you're getting paid for from what you are getting paid for, and are you getting paid for the right amount. That's the only way that you can really increase your revenue. And that's one thing that I can say that we did here. We maximized the meetings. We met sometimes twice a month and had to go in person to the insurance company to speak to someone at a higher level because we weren't seeing any results. So the relationship between insurance company and your facility is key to you getting paid. Many of those insurance plans have different lines of business, so that's another area that I would stress to anyone that's even thinking about going into third-party billing, is understanding the insurance world. Having a contract with the insurance company, they may have different lines of business, and you really have to understand those lines of business, that one line of business may pay for a service and another may not, and that's where your front desk comes in, and I'll talk a little bit about that, of your front desk staff, who are just as important as the provider treating the client, because if they don't collect and ask the appropriate questions, which I have to say has been one of the most challenging parts of my career, of really getting the right front desk staff, as well as trainings and updating the front desk staff when something changes at the insurance company. The staff need to know, and that's another role of the credentialing specialist, is really building those relationships, looking for updates, and updating our team. Using the insurance information provided by the patient, the front desk must confirm which services are covered and the patient's current insurance, because of our Medicaid population and the Medicaid managed care population, insurance coverage can change at midnight. And we can't assume that health insurance plan that client has will be the same every time they come. So it is a tedious process, and if you go to the next slide, I can go a little bit more into detail of the infrastructure of how it looks and really what happens from beginning to end, which a lot of people are more familiar with the revenue cycle, but we actually have outlined it where it's information flow, and it starts with our call center where the calls come in. We have eligibility specialists. We have authorization referral department in that same call center where they make appointments and they actually assist with PCP changes. And the reason why it's very important to really understand the job of the call center, because that's where your revenue cycle starts. That's where the staff that work in that department will need to know what each insurance plan either will pay for or what they will not pay for. And if you look at the arrows, the credentialing specialist, which the task of the credentialing specialist here at the agency is not just credentialing providers, but setting up our new patient portals. Actually, we'll go and open all of our checks, meaning going to pick them up at the sites that they are mailed to, and reviews everything to see if whatever we're not getting paid for, that the credentialing specialist will work with the billing team and highlight those areas, and then we go into a denial meeting to talk about that. So there is a tedious process, but believe it or not, for the size agencies that we have one credentialing specialist currently who has been with us for a couple of years, but the job has expanded to more, and it's very important to have the right people. From the credentialing specialist, working with the managed care department, collecting data to submit for authorization, submitting data to the insurance company, speaking with the insurance rep, and actually making sure you have the appropriate authorization, again, ties to all of your payments. And then once the actual checks, if they're electronic versus paper, once they come in, there's a whole nother level of review. And from the credentialing specialist to me, they actually come to me for me to review, because the billing department reports into my portfolio. There's a lot of eyes and hands touching our denials as well as our payments. And the denial meetings, we talk about the in-depth knowledge of what's going on with our denials. And that's and I'm breaking down right now what's going on under our HIV primary care billing. Next slide. And then we have our 4 components of billing. And I am going to start to the right where patient services. We have appointment scheduling, patient enrollment, eligibility verification, pre-certification, and pre-authorization. I will share with you, if anyone is on the line that plans on going into or moving into third-party billing, that particular area you really need to invest in, because without an authorization, the appropriate authorizations, you will not get paid. And if that's in your contract, most of the time the insurance company will not actually backdate. Eligibility verification is the actual agency's responsibility to make sure that that insurance is active, and if it's not, having the client sign the appropriate paperwork of who's going to be the responsible party. Then we have the billing services, which would be our CPT, ICD-10 coding, billing and charge entry, claim creation and claim submission, which is another area where we work with our clearinghouse very closely, and the payment review, which would be the payment review, payment posting, and denial posting. And then if you look at our aging services, which would be our denial follow-up, denial analysis, follow-up with insurances for outstanding receivables, and patient account follow-up. All of these areas play a pivotal role in our increased revenue over the years. And what I will share is that our collection rate has gone up over the last 2 years at a peak, where when we outsourced our billing, we were at a 50 to 60% collection rate. We're averaging now anywhere from 78 to 84, and that depends on, again, month by month of what's going on with the client's insurance, as well as what's submitted in that month. If we go to the next slide, I can actually explain a little bit more about the revenue cycle, which is very repetitive, but it changes depending on what's going on and who is actually coding. So our first presenter talked a little bit about the credentialing of providers, the sites, depending on where a provider is actually working, and if they're credentialed at that site, can lead to denial if they're not actually credentialed with a specific site. And if they're not, what we learned over through trial and error is making sure that we try to add all providers to all of our sites, if it's possible. Some insurance companies will have restrictions to the 16-hour rule, but you need to really speak to the individual insurance companies to see what flexibility they have with covering providers. And all of this needs to be in your contract. So you can have conversations, but your contract should read this, because if it's not, once you submit those claims, and once the claim goes through and it's, if the insurance company doesn't pick up what you agreed to or what's in your policy, you're going to get a denial. So it's just delayed payment, and it helps with you working out all of those kinks. Next slide. And then what we shared with you today is typical scenarios for HIV screening and PrEP initiation. And you can go to the next slide. And what I'm sharing with you today is really a typical annual visit as part of the annual visit for our providers when they're treating our clients, of the codes that are used on a regular basis, as well as the lab codes. And what we've learned, again, some of these codes, keep in mind, may not be in your contract. Speaking to other agencies, and actually initially when we brought billing in-house, there were several codes at the time that weren't even in our contract that we had to add. So the codes that you are seeing are the codes that we use for annual. And then the next slide, which is similar, the same for PrEP initiation. And then the last, which would be similar PrEP initiation. But the one thing that we had to really work out the kinks for some of our PrEP, we have a few PrEP grants, and that screening process and actually tracking is something that you would want to do in your agency if you have been funded through a grant for PrEP care. But what we have noticed is that when we speak to our insurance company, the insurance companies, and explain what we are doing if it's denied, and each insurance company is different. Some will pay, some will not, and if they don't, we want to sit down and talk to them and say, listen, you have to have your data too. The one thing that we did a really great job at was collecting our own data and going back to the insurance company, because the insurance company has their data. And sometimes the data that you have and what they have are not the same, and it's negotiating. Smaller agencies have, I would say, more challenges when it comes to trying to increase or add codes or change your contract, but you really have to build those relationships, and they want you to actually continue working with their clientele. Most, if not all, of the insurance companies that we spoke to, they were willing to negotiate with adding codes that were not added. And that's the end of my presentation. I'm open to any questions that people may have.
Great. Thank you, Tanisha. Thank you so much. And thank you to Amy, of course. And we have a lot of questions that have come through our Q&A box. And so we're going to be reading those out to our two presenters, and then we'll be having a nice Q&A discussion for the remainder of this presentation. So what we're trying to do is go back to the earliest questions, and we're going to try and go in that order. So the first question is a question about reimbursement for HIV testing counselors who are not licensed. Is it possible to get reimbursement for HIV testing counselors who actually don't have you know, a more formal license? And so Tanisha or Amy, I'm wondering if either of you would like to address that question.
So I can talk a little bit about that if Amy doesn't mind.
Sure thing.
What we have done with something like that is really to make sure, one, if they're not licensed, because sometimes it's what we've seen, I've actually heard from other agencies too, well, I heard that the insurance company doesn't pay for that. That would be similar to what I was discussing earlier, of going to the insurance company and asking, this is what the particular individual will be doing, and if it's not paid by that particular individual, is there anything that we can bill under the services that they're actually providing, or do you have a code? Because sometimes individuals and insurance companies don't like to share that info, but again, it's the relationship building and asking the representatives a little bit more in detail. We also have found out that or noticed here at Harlem United, if it's not a covered entity by a provider that's not credentialed, we also would like to know why or who else can actually provide those services. and looking at the flow of the clinic, and actually looking at the flow, meaning that you may be able to fit that into the visit, but it doesn't have to be the provider, but it's actually a higher level visit because that's the extension of what's going on in that visit. So the provider may ask someone else to come in the room. So could it be at a higher level or going from, and I'm just giving you an example, a code like a 99213 or 99214 of expanding the time with the patient and the billable provider.
Great, thank you, Tanisha. And also just wanted to say that if there are questions that are not addressed or if we need further conversation about some of these answers, we are very happy to talk offline. And so we'll make sure that our contact information is available at the end and we can continue these discussions post-webinar. Because obviously there's a lot of information out there, and again, as both Amy and Tanisha have alluded to, a lot of these things are very setting specific and also state specific. So we'd love to get deeper with you all if that was what you needed. Another question, just kind of a broader question, was, does this presentation address organizations who are not clinics? So this presentation was designed primarily for healthcare organizations, but the NASDAQ coding billing guide does address some considerations for community-based organizations, and so and we also again are a network of providers that can provide support to community-based organizations. So if that was something you needed, we would be able to connect you to that capacity building assistance. Question 3 was about community health workers. What are other programs doing as to coding for these visits if they are not reimbursed for community health workers? So for organizations that are not currently reimbursed for community health workers, what are other programs doing as to coding for these visits? So I'm wondering if either Amy or Tanisha would like to address that question as well.
This is Amy. I can start, and then I don't know if Tanisha maybe has some sort of concrete examples to give based on what Harmony United is doing. But I mean I would just separate the community health worker is a provider type from the services. So the services could be provided, in some cases it's by a community health worker, but it could also be provided by a nurse, someone with another licensure. So those, if a payer says we won't reimburse for these services that are provided by a community health worker, we require a certain type of licensure. It's not that you're saying all those services are X'd out. It's just that those services have to be provided in the setting type and the provider type specified by the payer. And so as we talked about, those requirements vary by payer, by Medicaid managed care plan, and commercial insurance plan. So that's I think the best way to kind of address it is that there are very few plans, and it's mostly in Medicaid, some state Medicaids that are doing it, that do allow community health workers to seek reimbursement for services. The vast majority do not, but those services, if they're provided by others with the appropriate licensure and the appropriate setting space, can get reimbursed.
I can share with, this is Tanisha. I can share with you community health workers under the Harlem United umbrella. They may not necessarily have that title, but we currently have grant funding for employees that can assist with care coordination. So again, I agree with what Amy said. It's really hard to really work with the insurance company depending on the actual job duties, as well as if they're not a billable provider. And even if you're offering the services, we've had these conversations with insurance companies. They will say to you, well, we have a similar type of community health workers that can assist the client doing the same thing, so why would we pay you? And most insurance companies, they do have a similar role that works with their clients. So that was not, we would need our own, and that's why we have applied in the past for grants. Some of the grant funding has changed, so that's something that we are looking at, as well as we would still like to provide the services. And I know one out of the, off the top of my head, HRSA is really looking at this right now too, on how can we pay for or how will they pay for future funding in the near future in regards to certain services that are being provided that may have been grant funded from other entities, but that type of funding is actually decreasing, but we still want to provide those services. Enabling services is the word I was looking for. So enabling those types of enabling services.
Great. Thank you, Tanisha, and thank you, Amy. So here's another question, which is, actually this is for you, Amy, which is, does the guide mention anything about bundled payments? Some agencies noted that they have bundled payments and they're not quite sure how they can bill and be reimbursed for HIV if there's a bundled payment agreement in place with insurance companies.
Yeah, I can answer that. And you know, the short answer is no. The guide does not go into detail about sort of the ins and outs of dealing with bundled payments. It really focuses on, you know, pairing up the HIV prevention service with the appropriate CPT code and you know, the diagnosis code. So you know, I think that gosh, that is the topic of, you know, a whole separate presentation and probably another guide. And you know, that was one of the challenges that we sort of noted at the outset, that bundled payments is the direction a lot of payers are moving in, and you know, particularly for FQHCs, they're very familiar with bundled payments, as are other institutions like emergency departments, and so you know, we're seeing that's a problem in terms of making sure that the reimbursement rate for that bundled payment, whatever it is takes into account what you're trying to get in there, which would be the you know, HIV testing in many cases, or the other HIV prevention services. So I think that's all I can say about that. The guide does not specifically go into detail on that, although we have seen that and have, you know, tried to provide some resources and sort of peer-to-peer information on that. I don't know if maybe Tanisha has anything to add in terms of what Harlem United is seeing on bundled payments, though.
What I can share that's very brief is that with bundle payments, what we've noticed once we realize that it is a bundle payment, there are setups in your electronic medical record that you can work on of setting it up as a bundle payment, so you're not continuing to bill out and know you will not get paid for those services, or setting it up in the electronic health record if you're billing out of that same system as an alert to make sure that when you're billing out that it's not going into your aging report that you're expecting this particular money, or thinking you're going to get paid for 3 codes or 4 codes when it's really a bundle payment. And that's what we have done historically if it comes up as a bundle payment, to really track that. And that's the level of tracking of making sure you have enough skilled employees to actually look into the details of what's going on with why you're not getting paid for certain services, and if you're not, of fixing or setting up your electronic health record to pick up these different types of concerns that can come up.
Okay, thank you. Another question that's kind of directed a little bit towards NASDAQ, but I think Tanisha, you might also have something to add here, which is about guidance on how to code when you have patients that need to test for HIV more than once a year. So, you know, any thoughts about strategies for coding besides, you know, perhaps your new patients, your annual patients? What codes to use when you have people that need to test for HIV, you know, have an HIV test more than once a year?
So, Amy, I don't know if you want to jump in. Okay.
Well, I'm going to let you take the majority of this, Tanisha. I'll just say that the coding guide does address that very situation, and you know, the situation anticipated is for PrEP. That if you're on PrEP, the recommendations are to be tested multiple times per year, and so you know, the routine screening becomes a sort of, many payers will pay for the routine screening as part of the USPSTF recommendations once per year. And then, you know, the additional screening has to be coded as diagnostic screening, and the codes and modifier in particular for those 2 things are different. So that's included in the coding guide. But I am not a certified coder, so I will turn it to Tanisha to add any more details on that.
So one of the examples that we have seen here at Harlem United is that the doctor will take care of the client based on what the needs are and medical necessity. And even though the insurance company may say it's not a covered entity, we appeal certain things and actually will win the appeal, because if it's needed to take care of the client, and depending on what's going on, and some of those clients may not be on PrEP, the doctor will proceed with actually trying to get the approval for the lab visit prior, which would be the authorization part of what I was discussing. If not, we'll still actually proceed, and actually if we get denied, we would actually appeal it, which is another process, and that's why the appropriate staff to really manage this. It doesn't happen that often, but the doctor would have to actually write up the reason why and the medical necessity reason of why they would proceed with doing additional testing. Again, we would try to get the authorization prior because the doctor is explaining what's going on with the client based on what the client is sharing in the visit. But yes, that's client specific, but we would proceed, and that's just as a FQHC and Article 28, we meet the clients where they are, and we will actually fight, meaning going and proceeding with the appeal to make sure that we get paid, and that could take 1 to 2 appeal letters and getting on the phone to explain, or the doctor talking, the medical director at the health insurance company speaking to our chief medical officer here.
Okay, thank you both. This question is directed towards Tanisha. How does insurance verification impact clinic flow? How does insurance verification impact clinic flow?
Well, the insurance verification is a step-by-step process. So we have eligibility specialists. We have 2 currently at the agency that work on eligibility. Actually, we just hired another one. 3 to actually work on eligibility 2 to 3 days prior to the client coming in. Before that client is checked in at the check-in counter, they are actually going to be checking the eligibility again, because as I mentioned in the presentation, the eligibility can change overnight, and then it could delay. That's a very good question, because it could delay the visit depending on what's going on the day of the visit. But through the EMR, the providers are updated through messaging, as well as we would like to really work with the client, and sometimes the health insurance wants to speak to the client, and the wait time could be a little longer, but because of the flow and actually monitoring what the issue is or what we would have to discuss with the client, it varies, but the flow doesn't change dramatically because we know most of the time in advance, 2 to 3 days in advance, if the client's insurance or if it's active or it's inactive, and what we will need to do the day of when they are actually doing the eligibility check again when the client comes in before they're seen.
Okay, thank you. Another question about, a question about billing for HIV testing. So I believe this is directed towards you again, Tanisha, which is, do you currently bill for HIV testing? And if so, how do you get past the hurdle of charging for a service that has always been free and ensuring patient confidentiality?
So what we have actually been able to do with the Affordable Care Act changes that have taken place is that we have seen that some of those services that weren't being paid in the past, again, is going and speaking to your insurance companies about the services that are needed. For example, in the state of New York, and this, I don't want to confirm this, but across the country under the Affordable Care Act, there's something called comprehensive coverage. The law establishes a minimum of a set benefit called the essential health plan that must be covered under the health plan. And what falls under that, this actually includes many health services that are important for people living with HIV, including prescription drug services, hospital inpatient care, lab tests, and other to help manage other chronic illnesses. So it's really looking at the Affordable Care Act and really making sure that we understand it or understood what wasn't covered in the past that may be a covered entity, but the covered entity has to be added to your contract, and this is the detailed part of, it's part of the visit, and in the state of New York, it's actually required that we ask the client. They can say no, but would they like a HIV test? And we've actually dug a little bit deeper into what we can do in the state of New York versus what we can't do. and it is state-specific around the Medicaid guidelines.
Okay, thank you so much. So we have another question about HIV testing, which is, and again, I think it's going towards you, Tanisha, because it's about specifics with staffing. So which staff does the HIV rapid test, and which staff submits the bill?
Well, the rapid test is done in the clinic, usually by the medical assistant. The bill is actually submitted on the back end, which our billing team is at a different site. And then we have a different department, which is our prevention department, that does a lot of rapid testing as well. But that's actually grant funded, which is separate.
Okay, thank you. And I think this question that's coming up is related a little bit to a previous question about HIV testing and services that were traditionally free, which was, how do you build community support with transitioning from potential anonymous HIV testing sites to confidential testing while billing insurance?
So that's a good question. I think we're in the middle of that right now. And for us, we have contracts for PrEP specifically, that the client may come in and they're part of a research project with the funder, the grant fund, and they don't want their information being sent to the insurance company. And that's the tracking part of it specifically was referring to, that client's info would not go to the insurance company, and the grant, and that's part of the funding that we receive, would cover the cost of the labs and cover the cost of everything that we would actually be working and providing services to that client.
And Sarah, this is Amy. Just to jump in, on the privacy and confidentiality question. You know, because it's something that comes up a lot, and we get a lot of questions and concerns, you know, from health departments about that. And I just want to note, like, number one, the family planning and reproductive health community actually has a lot of great resources on this, because that is a subject that has come up in that context, you know, for many years now, in terms of making sure that information is protected when folks go to get a service and that it's paid for by insurance. And I would say, you know, on the HIV side, that has certainly come up, and we hear that as an issue of, yes, you're taking the anonymity away, because as a beneficiary, you're providing an insurance card that has your name and information on it, and your insurance is billed. But there are protections already built into the system, and then there are protections that a lot of states have sort of formalized in state regulation and law, you know, that where you don't get an EOB that specifies, you know, those services. So an EOB is an explanation of benefits. You often get that, you know, describing, okay, you went to X clinic for this service and we're billing your insurance X amount for this service. Most of the time, EOBs are only generated if you've got a payment that the client, the consumer, the beneficiary has to pay. So a lot of cases, you're not getting an EOB associated with those services. And when you are, there are some, you know, protections both plans have initiated and states have initiated them that X's out the actual name of the service to protect the confidentiality of the patient. So that's not to say that those concerns don't exist, but I do want to say, you know, it's something that many other providers outside of the HIV space are dealing with, and I think that there are some good strategies to sort of address those concerns and make sure that information continues to be, you know, safeguarded and confidential.
Thank you so much. So we're going to do about 2 more questions. We do have several questions I don't think we can get to in this time frame, but what we're going to do is collect all those questions and get back to you via email with either a response to your question or some type of resource that can address your question. But thank you for submitting all of those questions. So the next one that we're going to ask is, can't a credentialed supervisory physician obviate specific staff limitations in billing for services? So can a credentialed supervisory physician address, you know, some of the limitations we're talking about in terms of billing for services? Is that correct?
I'm trying to make sense of the question. Can a supervisory...
Right. When you have a physician who's credentialed and they're supervising other staff who perhaps are not licensed or what have you, can that actually support billing? Can that allow for billing for certain services?
that would have to be agreed with the health insurance company. And the one example I would use would be the PA and the MD. There are always questions, can a LM working under LC, licensed social worker, can we bill for that? Yeah. Technically, no. You should be billing under the billable provider that's providing the service. But it's a trick question because it's not the norm, and you shouldn't be doing it because the person, when they come to review your chart to audit, and it's not set up as a collaborative agreement or you working with, officially it's okay with the insurance company, they can take that money back. And I've seen practices actually, insurance companies have recouped dollars because of someone working under someone's license.
Okay. Thank you, Tanisha. All right, so I think the last question we're going to get to is, how do you incorporate PrEP and other billing into your 340B program? How do you incorporate PrEP and other billing into your 340B program? And perhaps, Tanisha, you could also just, for folks on the phone, what a 340B program is?
Sure. So under the 340B program, we actually get a discounted wholesale rate of our pharmacy drugs for our clients, which really helps with the overall revenue for FQHCs. It is a trick question, again, because I was at a conference recently about this. Again, that's individual based depending on each individual client, and you have to see if they actually qualify for the 340B program. That's a very strict run program, and here at Harlem United, we have one person that oversees that particular department, and they have other responsibilities as well. But the 340B program, the questions that can come up on an individual basis, just because someone has Medicaid doesn't mean that they actually qualify. And for PrEP overall, we would actually have to see if that person falls under our grant. So each person coming in is handled differently. No one is actually handled the same when it comes to, one, our 340B program, and the actual coding, and whoever is coming in to see what provider as well, because we have certain providers that work or see our PrEP clients, and then all of our providers are HIV specialists. So that's a very good question, but it's handled individually depending on the client's insurance. Do they even qualify for the 340B program? And that can vary.
And so this is Amy. I would just sort of add to that, from the sort of program, provider perspective. So NASA's been doing quite a lot of work on the PrEP financing front, including looking at, what are both the challenges and the opportunities for 340B entities to use that 340B status to, purchase, PrEP medications for clients, and obviously, attending to the patient definition requirements that Tanisha just alluded to. So I know we're about out of time, but NASAD has some resources that and presentations and other, sort of technical guides that we've put together to walk providers through the 340B considerations of PrEP financing programs. So happy to be a resource for that too.
Thank you, Amy, and thank you, Tanisha, so much. Obviously, we could go on, but we do have to end at this time. But on our slide right here is contact information for PCDC and NASDAD's capacity building assistance programs. Again, as we've mentioned, both of our organizations are funded to provide national training in TA, and we do often provide TA and training on this very topic. Tanisha from Harlem United obviously is a fantastic resource, and I said that a lot of questions were coming to her, and so we will definitely facilitate that conversation with Tanisha if there are additional questions that you all have for her. There's a final resource page that I'm going to show you as well that, kind of, I think is maybe listing some of the resources that also Amy just alluded to. We will send the slide deck along with the actual billing coding guide for HIV prevention, the link to the download that resource. And again, just want to thank our presenters so much for your wealth of knowledge and expertise. And thank you to all of our folks who registered and participated on our webinar today. So we will conclude at this time. And again, thank you so much, and please stay in touch.